So I'm going to speak today about what's happening in the United States and the responses that we've been able to develop to concerns about the safety of treatment de-escalation. Much of my work is thanks to my partnership with Dr. Miauchi and his team at Kuma Hospital and my colleagues in New York. So first of all, in the United States, in 2017, a very small number of thyroid cancer cases were due to aggressive types such as anaplastic, medullary, Hürthle cell, or follicular, but the vast majority, 90%, were papillary thyroid cancer, and this is similar to Korea. The incidence in that year was 51,000 cases, of which 43% of all thyroid cancer cases were papillary. They were 2 centimeters or less, and they were localized to the thyroid gland. These cancers are very low risk, and just to give you a sense of that, the mortality due to cancers that are that size and confined to the thyroid gland is only 1.4 per 10 million people. So very, very few people die of this kind of cancer. In fact, the 20-year cancer-specific survival of any size papillary thyroid cancer, as long as it's confined to the thyroid gland, is 98%, 98.5%. And you might wonder, why is this? Well, it turns out that many people actually die with very small thyroid cancers, never knowing they had it. And a very interesting meta-analysis of autopsy studies was done in which they looked at the thyroid glands of people who had died of other causes. And they found that if you look carefully, if you look at the whole gland, that 11% of people have a small thyroid cancer at the time of their death that they never knew they had while they were alive. This study also looked at whether the prevalence of thyroid cancer at autopsy had changed over time, because people wonder whether more thyroid cancers are developing. And they showed that there has not been a change in how common it is for people to die with thyroid cancer never knowing they had it. In fact, we just yesterday published a study using this information. And what we showed is that when you look at the autopsy prevalence of small cancers, it's actually the same in both men and women. And yet, small papillary thyroid cancers are detected 4 times more often than in women than in men during their life. So women are much more exposed to the treatments of these very small cancers that come to attention, often through testing for other reasons in the absence of symptoms. And in fact, if you look at the incidence rate ratio of cancer types in thyroid cancer, the more lethal the cancer is in the thyroid gland, the more likely it is that the ratio is moving towards 1:1. So you can see that actually the most aggressive cancers are approximately equally likely to occur in men and women. But women are much more exposed to this risk of having these small, very low risk cancers identified. Currently in the United States, a really nice paper came out from Toomey et al. Looking at the current treatment practices as of 2018. And although the guidelines suggest that many cancers could be treated with something less than removing the whole thyroid gland, 72% of cancer surgeries for thyroid cancer do remove the entire gland. But we know from looking at the statistics that more than half of these patients would be eligible for Hemi Thyroidectomy based on the likely stage of disease that they have. So we're struggling with this in the United States. We find lots of very small cancers, but we still treat them fairly aggressively. You might wonder who's actually eligible for hemithyroidectomy rather than removal of the whole thyroid gland. And in the United States, actually, whether you have a papillary or follicular cancer, if it's less than 4 centimeters, you can treat it with just removing half of the thyroid gland. If you don't have any lymph nodes, that also makes it suitable as long as it's still under 4 centimeters. Our guidelines actually say that if you have a cancer that's a centimeter or less, you should not be removing the whole thyroid gland. You, in fact, really should only be removing half of the thyroid gland unless you have an extremely good reason. The caveats for this are if an adult is older, if a patient has thyroid nodules on the other side, if they have a history of exposure to radiation, or if they have a familial differentiated thyroid cancer syndrome in their family. And this means 3 or more primary relatives who've had thyroid cancer. You might wonder whether the risk of recurrence is higher if we take our treatment from total thyroidectomy down to hemi thyroidectomy. But it turns out that in well-differentiated small thyroid cancers, T1 to T2, the recurrence rate after hemithyroidectomy is 2.3%, and it's only slightly higher after a total thyroidectomy with or without radioactive iodine. The likelihood of death is very low and comparable among the two. Median time to recurrence is similar. So we don't lose anything by de-escalating treatment for small cancers. It's interesting, Dr. Miyauchi is going to talk much more about this, but I was asked to comment on how we've adopted the Japanese practices to the United States. And it is important to note that Japan and Kuma Hospital specifically was the first to do this, and we have learned from them. At Kuma Hospital, active surveillance is used for cancers that are a centimeter or less, but here in the US, we are allowing cancers that are a centimeter and a half or less. They have to be a papillary thyroid cancer, of course, without lymph node metastases. We do a little bit less testing in the United States for a baseline. We just do an ultrasound and we check a TSH. We do check ultrasounds every 6 months for 2 years before we switch to annual. We've found that people are more comfortable coming in more frequently at the beginning in the United States and then switching over to less often. One of the questions that we get frequently is, what is active surveillance? And this is really important if you're thinking about taking this on yourself in your practice. Here's what it's not. It is not watchful waiting. When we say that to patients, oftentimes they have told us what they hear is that you're watching people die. It's actually very alarming. So it's not helpful language to use with patients. It is more appropriate to describe what it is. It is regularly scheduled ultrasounds of the thyroid and the neck to carefully monitor the tumor. And we intervene if it looks like it needs to be done, or if you change your mind, or if something in your health changes that tells us that we need to intervene. And active surveillance really is an ongoing assessment. The appropriateness of surveillance is reevaluated at each visit. And there are findings that might suggest that surgery should be considered if there's an increased rate of growth over time, if there's an increase of 3 millimeters in one dimension, or in the United States, if the volume has doubled. They're just different ways of measuring. In Japan, if the tumor reaches 13 millimeters, it's recommended to consider transitioning to surgery. If the cancer spreads to the lymph nodes, that's a time to do surgery. And if patients change their mind, that's a perfectly appropriate reason as well. In our work with Kuma Hospital and with my colleagues at Memorial Sloan Kettering, we came up with what we call the guide model of care. And in this model, the patient and the physician are partners in their care, and the decision is made together and is a path that is traveled together. In this way, both the physician and the patient can feel comfortable, they share information, and if a decision needs to be made to change treatment, they can do so together. It's interesting, active surveillance is still something that we're coming around to in the United States. A recent survey that was published by one of my colleagues, Dr. Megan Haymart, who did some interesting work in this area, found that 76% of physicians in the United States feel active surveillance is appropriate for some of their patients, but only less than half are offering it. And here are some of the concerns that people have. They worry the patient doesn't want it. They worry about patients being lost to follow-up, patient worry, malpractice. And so we're going to take each of these in turn because I have information that I think can help you. Here's a very common thing that we might hear from a patient or a physician. I know someone who had a tiny cancer and it spread all over their body. And what we can say to that was actually, yes, this can happen, but actually we can see high risk features before we decide whether to undertake active surveillance. People who have lymph node metastases, or if their cancer is outside the thyroid, those people are not appropriate for active surveillance. And we can say, we looked for these features. Your tumor does not show these. That's how we know that you are safe for active surveillance. Doctors sometimes say that they're worried about missing a bad cancer. And a similar patient concern is whether active surveillance is safe. A very nice meta-analysis combining data from several countries shows that at 5 years, about 5% of patients do have tumor growth, but only 1.6% develop spread to the lymph nodes. Nobody has died due to their thyroid cancer. And in fact, most people who undergo surgery have done so for reasons other than cancer growth or spread. Here's another common concern that we hear, and that is, well, my patients don't want it. But actually, it turns out that a lot of that depends on what the physician's level of comfort is. Dr. Saka did a very nice study that was published last year, showing that as patients were given decision support tools to describe active surveillance, if the physician also agreed that it was a good idea, most patients would agree to it. And this Dr. Miauchi will recognize from his own institution. I love this study because it shows how the physicians over time became more comfortable with active surveillance and offered it to more patients, and more patients accepted it. The dark lines here show the frequency of active surveillance over time between 1993, when they first started, and 2016, showing from less than 10% of patients accepting it up to more than 80 who were offered it. And truly, what we know about patients wanting it is that the patient's comfort reflects the doctor's comfort. You are like a guide on a trip being taken together. Both of you are evaluating the risks and the benefits and traveling the path together. Another thing that we hear concerns about in terms of active surveillance are physicians saying that they're worried people will be lost to follow-up, that patients will stop coming for their visits. And again, this is data that we did in our research with my partner, Dr. Miauchi, and his team. And at Kuma Hospital, over 10 years, patients stayed with their active surveillance protocol. At 10 years after starting, 72% of patients are still coming on a regular basis for their surveillance checkup. And you might wonder why this is, but we did interviews with these patients. And what they explained to us is that I'm just going to go back. They explained to us that the reason they came to their visits is because they wanted to see the results. They wanted to see that the cancer had not grown. They wanted to hear from their doctor and talk to them and understand that the cancer was stable and it was safe to continue monitoring. And in fact, the adherence to coming for checkups is remarkable. The adherence, meaning people coming within at least a year of when they last had their ultrasound, remains very high for several years, about 90%, even up to their 10th ultrasound. People keep coming back because they want the reassurance of their results and they want to hear it from you, the physician. People also worry that active surveillance causes too much worry. And in our research together, we found yes, people do have worry. About a third of people worry sometimes or more about their cancer. But if you look at the people who have their cancer treated with the removal of the cancer rather than monitoring, about a third of them worry also. They worry about the long-term side effects and recurrence. So I think it is probably wiser to explain to your patients that doing surgery or monitoring both create some worry because it's cancer and people worry, but surgery is trading one kind of worry for another. In conclusion, what I want to leave you with is this memory that thyroid cancers of any size that are confined to the thyroid gland at the time of diagnosis have a tremendously excellent survival, 98.5% at 20 years after diagnosis. First, if you have a small cancer, papillary type, that meets the criteria, first consider whether active surveillance might be an appropriate approach. Then consider hemithyroidectomy, and only last come to decide that maybe a total thyroidectomy would be needed. And remember this guide model as you work together with your patients, that you are traveling the path together. Thank you. I'll be happy to take questions at the time that it's appropriate in our discussions.